Okay, I think we will launch. This is Christine Toriuson from FHI 360. Welcome to the PrEP Learning Network. We are trying to be a little bit more interactive today, and so as you'll see, we have our speaker videos on so that you can see those who are speaking. Unfortunately, we do not have that ability to have videos for our attendees or have audio because we're trying to manage the sound quality, but you are welcome to post comments, questions, or share experiences in the chat function or on the Q&A. Today we are talking about a very important issue, addressing the elephant in the room and talking about how stigma affects PrEP rollout. Next slide, please. This is an overview of our session today. We will talk about what works for stigma reduction in health facilities, Kenya's experience with PrEP for All, and then we have a special presentation with sharing a video of a public service announcement actually that was developed in South Africa to combat stigma. Next slide, please. These are our speakers today. We're very glad to have Laura Nyblade with us from RTI International. She is an RTI Fellow and Senior Technical Advisor on Stigma and Discrimination. Elizabeth Arungu joins us from Kenya. She is the Deputy Site Coordinator for Partners Demonstration Project, and she has over 10 years experience conducting HIV prevention research and leads the Partner Scale-Up Project. Next slide, please. Just a little bit of housekeeping. We want to remind you of how the chat function works. So we have both a chat and a Q&A box. In the chat, you will notice next to the to line that it says there's a little arrow and you can select to send your message either to all panelists or to all panelists and attendees. We strongly recommend that you choose the all panelists and attendees so that everyone on the webinar can see comments and questions. You can also post your questions or comments in the Q&A box, which is seen by everybody. So, and we welcome your comments as we go along. So next slide, please. Okay, so, we're just starting off with the big question of why do we need to consider stigma in PrEP rollout? Next slide. As I think probably most people on this call are aware, stigma has a strong influence on PrEP use. Of course, there are many different factors that affect PrEP use and continuation. We can see some of them listed here in this word cloud. Some of these are much easier to address because they're more obvious. You have a side effect, you can talk about it, and you can do something about it. But stigma is a much more difficult challenge to address because it is so amorphous and difficult to define. But we are hoping to get some definition and some ideas about interventions for it today. Next slide. There are many different dimensions of stigma, and some of these are going to be addressed by our speakers today. Reasons for stigma are with PrEP use in particular are that it carries the stigma that's associated with HIV since it's an HIV prevention product. PrEP may be associated with specific marginalized groups in our population who also have a lot of stigma associated with them, or they may be associated with a behavior that is stigmatized in the society, such as if you're taking PrEP, you must be sexually promiscuous. So these are really challenging issues to overcome. Next slide. So in order, just sort of stating the obvious here, in order to increase PrEP use and continuation, we need to address stigma. We need to address it head on. And hopefully after today's webinar, we'll have some ideas of how to do that. Next slide. Okay, we're going to launch right into our first presentation. Next slide. And I'd like to turn this over to Laura Nyblade to talk to us about what works for reducing stigma in health facilities. Over to you, Laura.
Thank you very much, Christine. And good morning, good afternoon, good evening, wherever you are in the world. It's a pleasure to be with you today. And I'm going to be sharing with you some work that we've been doing under the Health Policy Plus project. RTI has been leading that work in Ghana and Tanzania, as well as other work that we've been doing supporting the Ministry of Health in Thailand with a national scale up. So I'm going to talk specifically about what we've been doing in health facilities, but there are some general lessons that apply also if you're working in communities or with families as well. So if I have the next slide, please. I'd like to start off by acknowledging that I'm presenting work that reflects the efforts of a lot of different people. This includes our respondents, facility staff, and the management and health facilities in Ghana, Tanzania, and Thailand. We've been working with the governments of these countries as well, and local implementing partners, and of course, those who supported the work, which included USAID, PEPFAR, and the Global Fund, as well as NIMH and the Ford Foundation. Thank you. Next slide, please. So I want to start out with some definitions and terminology around stigma. As Christine mentioned, sometimes we think it's difficult to define stigma. And so there are a few things that I found that are really helpful in thinking both about how we think about stigma, but then also with reflection on how then you think about intervening around stigma. So I wanted to get us all on the same page, which will then help understand why we approached it the way we did. So if you could have the next slide, thank you. So as Christine mentioned, stigma is not only an issue for PrEP rollout, we know it's an issue that is a fundamental determinant of health and health equity, that is who gets access to health. And we know that stigma undermines three key determinants of health. And this is work by Hatzenbuehler et al., which I find very helpful in thinking about why we address stigma. One is access to resources. So if you're thinking about PrEP, you can think about the fact that stigma might be keeping people from going to get PrEP, but it might also limit their ability to have access to those resources. So we might have stigma at the policy level that doesn't allow access to the PrEP resources. It undermines access to social support. Maybe your community is going to say negative things about you. Maybe your family is not going to support you to actually get to that PrEP. And then it affects our psychological and behavioral responses. So I might not want to go for PrEP because I'm anticipating that when I go to the clinic, I'm going to be stigmatized. I'm going to be talked to a certain way. I'm going to be treated a certain way. And so my behavioral response is just not to go. So we know that stigma undermines these three key determinants of health, and it does so through exclusion, segregation, discrimination, stress, and downward socioeconomic placement. So we know that stigma undermines a lot of fundamental things in our lives that allows us to be healthy and have good life chances. Next slide, please. So this is work that comes from Lincoln Phelan from the sociology field that comes out of work around mental health stigma. As we know, there are many medical conditions that are stigmatized, as well as many groups that are stigmatized. And this is particularly helpful in thinking about how you intervene and where you intervene. So we know that stigma is a social process. It's something we do to each other. It's not something someone holds, it's something we do to each other. And it occurs within the context of power. And that's important to think about in terms of what's happening. So for example, the dynamic in a healthcare facility, when I'm trying to get PrEP and the health provider is rather thinking that I should stop having sex, is that there's a power dynamic going on. So power is important when you think about the process of stigma. Who has the power and how is it being used? But this process we all engage in, and we all do it on a daily basis. The first is that we distinguish and label differences. So we say, this is a person living with HIV. This is a person who's taking PrEP. This is a person who injects drugs. So we're labeling, distinguishing and labeling a difference and holding it up in society as a difference. Then we begin associating negative attributes to it. Instead of saying that someone who's taking PrEP is being responsible, they're taking care of their health, we're more likely to say they're being promiscuous or irresponsible or immoral. So we're associating negative attributes to that difference we've held up, which is that someone is taking PrEP. And that allows us to start this process of separation, of othering. It's those people over there versus us. We're the good people, and we don't like those people over there. It's those PrEP users. They're promiscuous. They must be sex workers. So we start this separation. So we create this barrier, and we're othering the people and the difference that we've held up and that we've put these negative connotations on. And that allows us to really treat the person as almost as less than human. And so it creates this ability then to discriminate. And it's that difference and that separation that we've created that allows us to discriminate. What we know about stigma from across many conditions is that one of the most effective ways to reduce stigma is through contact. So getting to know someone. If you know someone and you understand that they're just like you, they have the same aspirations in life, it's very difficult to discriminate. So this is a process when you start thinking about interventions, thinking about where are you breaking this kind of chain or cycle. And you can think of it almost as a circle, because once you get stigma for one thing, it creates vulnerability for stigma for another thing, and you get this kind of vicious circles going on. So these 4 steps are places where you can intervene with your interventions. Next slide, please. So as any field, we have lots of different terminologies, and I think this is part of the challenge with doing stigma work. And I think the field has moved really far, especially in the past 5 to 10 years, around getting some very clear definitions. So I'd like to just spend a few seconds on that to get us to a certain place. Next slide, please. So it's important to think of the different types of stigma. As you're thinking about interventions, it's important to understand what are the types of stigma that are most salient, or the ones that are really keeping people from accessing PrEP or staying on PrEP. The first is experienced stigma, or sometimes we call this enacted stigma. This is the stigma that is enacted through interpersonal acts of discrimination. So this is when you don't invite someone to a family gathering, or when, and it still happens unfortunately, we separate people's dishes, for example. So this is the actual act that we do. Can you hear me? I'm just getting a sign saying the speaker isn't working.
It is breaking up.
Okay. Is that any better?
I think that is better.
Okay, I'll just lean closer. Sorry, you're going to get a really good close-up of my face. It just flash something up if you're having trouble. So I'll go back. So experienced stigma is the actual enacted stigma that we engage in. Perceived stigma is what we think is out there. So that's the perception of the prevalence of stigmatizing attitudes. It could be in our community, it could be in our church, in our mosque, among our healthcare providers. So this is what we think is out there. What we think is out there is important because that can affect our behavior. If I think that everyone at the health facility is going to be stigmatizing, then I might not go to the health facility. Anticipated stigma is slightly different. This is the fear of stigma. This is, we anticipate that this is going to happen to me. So if I disclose that I'm using PrEP to my partner, they're going to leave me. So this is the, I see there's another message. There's an echo. I don't know what to do about that.
I think it's your internet connection. I think you just should continue.
Okay. And then there's internalized stigma, which is what we take on to ourselves, which we internalize. So we accept that what's out there, we think what's out there, or what we've experienced is valid or justified. And so it's internalized. And it's important, and there's one more slide of the definitions, please. Next, there we go. Secondary stigma is the stigma by association. So this can be extended to family or other caregivers of the person who's experiencing the stigma. For example, healthcare workers might be afraid that if they are providing PrEP, that other people are going to stigmatize them, or for example, if they're providing PrEP to young people, their parents might be upset by this. So thinking about the people who are providing, or the people around someone who's trying to access PrEP, and whether they're afraid that they will be stigmatized. For example, a parent, how could you let your child be on PrEP? Observed is what we see happening, and what we see happening affects our behavior. Structural stigma is the laws, policies, and institutional architecture that may be stigmatizing or alternatively protective against stigma. And then intersectional stigma is where we have the convergence of multiple stigmatized identities within a person or group. So these are the intersecting stigmas faced. So I think Christine started us out today talking about how PrEP is stigmatized for multiple reasons, and there could be, in an individual, there could be multiple intersecting stigmas happening, and it's important to think about that as you think about how you respond to stigma. So these definitions are important because we know that there's studies that have shown us that different types of stigma have different effects on different types of health outcomes. So when you're thinking about how you're going to intervene, it's important to think about this. So for example, with PrEP, I would think, I don't know, but I would think that anticipated stigma is a very important factor, that there's this anticipation that this will happen to me and therefore I won't, or I won't stay on PrEP. Or if you experience stigma when you're on PrEP, then that might stop you from continuing. Next slide, please. So I want to share what we've learned over the past 20 years. I've been working on the issue of stigma for 20 years, and talk a little bit about some key principles that we've learned for stigma reduction programming that we find apply across many different areas, whether it's stigma around HIV, whether it's stigma around same-sex, sexual orientation, whether it's around gender identity, whether it's around sex work or people who inject drugs. We've found that we can apply these principles sort of equally. So I think they will also work for PrEP. Next slide, please. Just to, Christine already talked about this, so I'm not going to spend a lot of time, but just understanding that obviously reducing stigma towards PrEP is going to help with the HIV prevention cascade and ultimately reduce the risk of HIV infection. But where I'd like to focus your attention is on the left-hand side of the slide, where I talk about immediately actionable drivers. And we use this term on purpose, and what we've learned over the years is that stigma, as I talked about, is a social process. It's embedded in our societies, and it's embedded in power. And so it can feel quite overwhelming. It can feel like something we can't actually address. But what we've learned over the past 20 years is that you can address it, and it's important to do two things sort of at two levels. So one is focus on the things that are immediately actionable, where you'll see a change immediately, while you're working on that larger social change that we need to have happen. So thinking about what are the things that we can change right now that will see some tangible results and make stigma much more, feels like we can do something about it. And what we've learned from HIV is that there are four actionable what we call immediately actionable drivers. The first is that in HIV, we still have fear of contracting HIV in ways that we know we cannot contract HIV. Even among healthcare workers, we find that we still have fear that one can contract HIV in ways that you cannot. You can translate this for PrEP and thinking about what are the fears around PrEP. So what are the fears that we need to address and understand, the things that might be in people's daily lives that they're afraid of around PrEP that might be driving stigma. The second is awareness of stigma. And this is simply that we all stigmatize on a daily basis without knowing that we're doing it. It's unconscious. We're not aware of it because stigma is such a socially embedded process that it's become part of the way we live, what we do. And so creating awareness of stigma, of what it is in more concrete terms, in the words you use, in the tone you use, in some of the actions we have, that can be really powerful, just simply creating awareness of what stigma is. I can't tell you the number of times we've been doing these participatory stigma reduction workshops that I'll tell you about, where it's been like light bulbs going off and people are like, oh my goodness, I didn't realize I was stigmatizing. And something as simple as that can create a lot of change. Then there's our attitudes, the values and beliefs that lead to the judgment, the shaming, and the blaming. And it's important to understand where those come from and how and get them out in the open so we can talk about them. This is often a fine line that you have to walk with stigma reduction, in that you're not asking people to change their religious beliefs, for example, or their deeply held beliefs, but helping people understand how attitudes are shaped and how that can then be stigmatizing, especially in delivery of services. And then if you're working in a healthcare facility, or if you're working in a faith community, or even in a political structure, understanding what the institutional environment is and whether it supports non-stigmatizing behavior. So, and I'll give you some examples of this. So just a framework to set up thinking about how you can intervene on stigma. You can also measure at these two levels. Next slide, please. So we've learned some key principles for stigma reduction, and I'm going fast because this is short, but I'm happy to share more resources with people. One is that I just talked about, which is addressing the immediately actionable drivers. And these are in no particular order. The second is putting the groups that are experiencing stigma at the center of the response. So this needs to be focused on the PrEP users and having PrEP users involved in developing the stigma reduction interventions and leading the stigma reduction interventions. But it needs to be done in a way that's respectful and safe. So with people living with HIV, we know that networks are extremely important. We know it's important to develop the skills to interact with the public around stigma or leaders, and then to address internalized or self-stigma. So even with PrEP, I think you might find that people who are using PrEP have internalized some stigma around why they're using PrEP, and that somehow they're lesser than, or they're by using PrEP, they're not being good people. So thinking about what the internalized stigma might be around PrEP. And then the last piece is really creating partnerships between those who are experiencing stigma and opinion leaders. Opinion leaders are called different things, but people in the community who can shape other people's beliefs and behaviors. And we know contact strategies are an important way to do this. That's when you create safe spaces to bring together people who are experiencing stigma with those who are the stigmatizers, to start breaking down that us and them that I talked about earlier, that othering. It also helps to build empathy, and also working to model desirable behaviors and recognize and reward role models. So helping those who are stigmatized understand the kinds of behaviors you do want, or that you would like them to do, not always just saying don't do this or don't do that, and that's important. So I can give some examples in the question and answer about that. Next slide, please. Lots of stigma reduction tools out there. I'm happy to share these. A lot of these are ones that started from an original toolkit, and they've been adapted for different types of stigma. So lots of resources out there. Next slide, please. I'm going to talk about an application of a training package for health facilities that was developed under the Health Policy Project, and I'll show you how it gets implemented. This original toolkit was based on field application in 9 countries, and it can be tailored for different audiences and timeframes. It includes 17 sample workshops. So oftentimes what we get from, we have these set of tools, and what we've learned over the years is we created them to allow for lots of different options for adaptation. And what people came back to us and said was, could you just tell us which ones work best for different types of audiences? So that's what this is about. So just to say again that you have this resource out there, and the original toolkit was a generic toolkit, so it can be applied in communities and with different types of opinion leaders. Next slide. So I want to give you some examples of how you can put how these principles have been put in place and how these tools can be adapted, just to give you a flavor of how this can be done. Next slide, please. So I'm going to talk specifically about the work that was done in Ghana and Tanzania. And we developed what we call a total facility approach to stigma reduction. And the reasons for this is that we really know that stigma oftentimes starts at the gate or at the reception, and that that can be enough to turn someone away, particularly if you think about a young person coming for PrEP, how the interactions they get along the way to the provider who's going to prescribe PrEP can have a big impact on whether they actually make it to the provider or whether they come back. So thinking about how you change a whole facility or a clinic or wherever the PrEP rollout is happening as I explain this. Next slide, please. So the total facility approach had 3 parts to it. The first was, obviously, we were evaluating it. So we had baseline and endline, but I want to talk a little bit about the baseline as being, as part of the intervention, because the surveys that we did, we took them back to the health facilities and had participatory workshops where we had the management in charges of the different units working with the data and analyzing it. So the data really kicked off the intervention, as it sort of allowed the staff to think about what's going on and to validate the data. Is this really going on? And then start already thinking about what the interventions might look like in their clinics or their facilities. And one of the things that came out of the baseline was that we need training for our staff. So we adapted some of those global training tools I talked about, in particular the HPP toolkit. In each country, we had a process there where we worked with both national and facility stakeholders, as well as people living with HIV and members of key populations, to adapt the tools. Then we did what was most important, or one of the key principles of this approach, is that the training was then done by staff from the facility along with clients from the facility. So we had client staff trainer pairs who then delivered the training to their peers in the health facility. And this was really important because it wasn't outsiders coming in to tell people what to do around stigma, but it was their own peers training them, and then they all worked together then to develop stigma reduction interventions for that specific facility. And with an issue like stigma, which is very sensitive, that's important that it's not outsiders who are doing the intervention. So we had a 5-day training where we trained these trainers on this methodology and the content, and then they went back and delivered the training. And then obviously we had N-line. Next slide, please. So as I talked about, the training of facilitators was really important, so that this also builds capacity within the health facilities to continue. Some of the facilities now do training as part of their onboarding because they have the trainers in-house. We learned from Ghana and Tanzania, we had a competitive selection of facilitators, which was important. We work with management. We have certain criteria about what makes a good trainer. And then they get this 5-day of offsite training, as I said, and 5 days of mentoring or coaching as they're starting to roll out the facility. So on-site coaching is really important. They then deliver these, in this case, it was a 2 days on-site participatory skills building for facility staff. And this might seem like this is really difficult to do, but it actually worked fairly easily. The training is modular, so you can you can implement the timing in whatever way makes sense. So for example, in Ghana, they did 2 days straight because they were able to rotate their staff that way. Tanzania, they did it 1 day and then another day a couple weeks later. In Vietnam, they're doing it 3 one-hour sessions over an afternoon. We're doing something similar in South Africa on a NIH-funded study. So it's very flexible. The other thing we do that's really important is that we mix different levels of staff. So we train doctors with cleaners, with nurses, with guards. We were told this wouldn't be possible. It worked beautifully, and I can say more about that in the question and answer. So again, it's very flexible. And again, you could adapt this for lots of different kinds of settings, this type of model. Next slide, please. This is just some of the, these are some of the tools that we use, or the actual exercises. And I wanted to just pull your attention to the fact that they address those actionable drivers. So we have one that's around creating awareness. There's one around understanding fear and addressing the fear. In Ghana, we also focused on gender and sexual diversity stigma. In Tanzania, we focused on stigma faced by youth seeking HIV and other sexual and reproductive health services. So we had additional modules that were added in addition to the basics that we developed. And so you'll see these modules focus on those actionable drivers I talked about. And then lastly, we talk about change. So throughout these 2 days, the staff are actually developing ideas for their own interventions that would be practical and feasible and needed in their particular facility. Next slide. So just wanted to say that after these 2 days of training, and we had aimed to train between 50 and 70% of the staff in each facility. And what happened was, after the first couple trainings, which had managers in them, the managers came back and said, no, actually you need to try and train all of our staff. All of our staff need this. So, and in Tanzania, we actually got 100% of the staff trained, and in Ghana, depending on the size of the hospital, between 70 and 90% of the staff were trained. And this was really important because all the staff were then on the same playing field. They had the same knowledge, the same information, and part of what we do is in the training is also how to challenge each other respectfully and gently when you see stigma happening. And we actually saw some of that happening afterwards. But what's important is that the staff themselves come up with their own solutions for what's this. And what we saw from the training is that these champion teams, as we named them, emerged kind of organically. And we worked with the management to actually make them kind of official. And they developed lots of different low-cost interventions, some no-cost interventions for their facilities. And again, I can say more about that later. Next slide, please. So these are the key elements. I've already talked about these. I won't spend time on them, but really important that it's the training that happens in the facility, that it's facility-led. And I think this is a really important principle for stigma reduction in that, because it is sensitive, that you develop the skills and to challenge stigma within facilities and have it facilities or communities or communities of faith to actually do the stigma reduction, lead the stigma reduction from within is important. The other thing is that the participatory piece of the stigma reduction training is really important. So our trainings are 100% participatory. They challenge people, but they're also fun. So people enjoy the training. And that piece is really important, particularly when you're trying to change something like stigma. Next slide, please. Just want to say, I'm not going to spend a lot of time on this. I know I'm out of time, but just to say that we've been working on this, supporting the Ministry of Health in Thailand as well. And they have a similar approach, and they are actually scaling this up nationally. So I just wanted to share, because oftentimes we say stigma is too difficult to address, to say that you can actually address stigma and you can actually do it at a national level. So next slide, please. So Thailand has embarked on a process of making stigma part of their response to HIV. And this is just a timeline to show that they've been doing lots of different things. Just to highlight two things. One is that they have what they found was really important was that they put stigma reduction into their national strategic framework. It's a goal alongside prevention and treatment. So it's at the same level, and that forced them, which they wanted, to be accountable to that. So now they're measuring stigma. They measure it every 2 years in lots of different, and 3 or 4 groups. And they hold themselves to account. So they look at what's happening over time on that. And then they developed, based on this kind of total facility approach, an approach that's for Thailand, they call it the 3x4 approach. And they're rolling that out and they're adding different things. They've launched some e-learning alongside their in-person training and other things. So just to say that you can actually reduce stigma at a national level and scale up. So Thailand is leading the way on this, and I can share there's some papers coming out on this work. Next slide, please. So this is their 3x4 approach. It's the same sort of thing, actionable drivers, different levels of intervention. They're working at the individual systems and structure, and then linkages beyond the health facility. Again, this is their health facility approach. They're doing lots of other things as well. Next slide. This is their national framework for measuring stigma. Again, just want to make one point here that you can measure stigma and you can measure PrEP stigma as well. I know there's starting to be some scales out there. So it is measurable and it is actionable. Next slide. Next slide, please. So just want to end by saying action is possible, whether this is on HIV stigma, PrEP stigma, gender and sexual diversity stigma. We do have some standardized and validated tools for HIV stigma that I think, and there are more, I know there's some out there in the works for PrEP stigma. Important to make stigma reduction part of all your programs. So as you're thinking about your PrEP programs, thinking about how you integrate stigma into those programs very deliberately, As we know, it's a big challenge to our success on many fronts. So you can, if it's around the health facility, you can do it by making it part of your quality approach. So you integrate it into your quality improvement processes, into all of your training, and then thinking about how you leverage synergies for stigma reduction. So we know, as Kristen started out, that there's stigma for multiple reasons, or there might be stigma across multiple conditions. So how can you leverage what's already going out there, for example, around HIV stigma reduction? Next slide, please. Just to end by saying it is possible to address stigma and to reduce it. So I hope that this helps, and I know our next speaker is going to give you a very practical example. Thank you.
Thank you so much, Laura. That was really incredible, very comprehensive, and one of the best summaries of stigma that I've ever seen. So I really appreciated that. Let's see, I have one question in the chat, and others can feel free to put questions in the chat. From Jen Mason, she says, how do you ensure that management staff or clinical staff do not lead the conversation during the training? Have there been any secondary outcomes from the training, such as improved communication or cohesion among trainees in their routine interactions in the workplace?
Thanks, that's a great question. So it's how you set up the training. And this is going to sound really hokey, but it really makes a difference. So first of all, it starts with making sure that those who are leading the training are strong trainers and are able to manage this mixed group of people. One of the first things we do when people come in, obviously, the first day of training is getting comfortable. But one of the things we do is we talk about how our identities. And in Tanzania, for example, they create paper hats, and you write all your identities on the hat. You know, I'm a doctor, I'm a nurse, I'm a mother, I'm a grandmother, I'm a sister, I'm a brother, and they all go on the hat. And then we talk about them. Then the hats come off and they all go into a corner. And we make it clear that your identities are really important. We're not trying to change your identities, but the identities when you're in this room stay in the corner. And you can pick up your hats and take them as you leave. So everyone in the room is at the same level. And it's interesting, within about an hour or an hour and a half, the doctor or sister in charge monikers have disappeared, and everyone's on a first name basis. But again, this is where the training of the trainers is really important, to be able to do that. One thing we didn't measure, but we heard a lot from the management, was that this has completely changed the dynamics in our health facilities. The staff are working together better. Our guards, our cleaning staff, our receptionists are really becoming part of the team and seen as part of the team. I think one of the most poignant things I heard was from a guard who said, I never realized that I was part of someone's healthcare, that how I greeted them at the gate, how I directed them, that I could give them help made a difference. Also changed the dynamics. We had another guard who said, now I can talk to the doctor when he comes through the gate or when he's coming back. And, I can see when he's had a hard day, and before I could never say anything, and now I can talk to him and give him comfort because I know, he's had a really hard day at the hospital. So it really has changed the interactions. We've also heard that even in larger hospitals where sometimes it's even hard to get someone from a different department to help your client when you need them to help them, that has changed now too, because they have a personal relationship. So this is, it was actually, and it's not, there is a strategy to it, but it's not rocket science. So, and it can make a huge difference. Does that answer the question?
Yeah, that's great, and a wonderful example. I think, we will share the links to some of these resources in our resource sheet. Brian Pedersen, would you go ahead with your question?
Yeah, Laura, so thank you so much for the great presentation. I agree with Christine that this is one of the better explanations of stigma, which I think you touched on very nicely about how it affects so many different behaviors along not only HIV prevention, but HIV treatment. My question is about involvement of specifically key populations. So, several years ago, I remember hearing a story about a group of men who have sex with men having a meeting up in the north of Ghana. And when local community members learned that they were there, they called the police on them to come and clean out men that were there doing what they perceived illegal activity. So I'm curious, in countries where, not only being socially stigmatized, but also being technically illegal, how do you ensure that those populations can participate in anti-stigma activities in such a way that they feel that they're being heard, that they're being appropriately engaged, when there are, structural reasons that cause them not to be fully engaged, not just social reasons?
Yeah, no, that's a very important point. And as I, and it's something that you have to engage in very carefully. So when you think about those key principles that I talked about, it needs to be led by the people experiencing the stigma, but it also has to be done safely. And so sometimes you might have to come at it from a different direction. In our work, the engagement has been working through networks. And both in terms of designing the questionnaires, the baselines, as well as the adaptation of the tools, but then most importantly, as trainers. So having key populations as part of your trainers who work alongside the health workers. And what we find even in that, when we're training healthcare workers with clients to be the trainers, that we see a lot of stigma reduction already happening there. And then again, part of this training, we always have a panel that in Ghana, for example, it included people living with HIV, MSM, sex workers. Again, these have to be people who are in a place that's safe enough for them to come to a training like that and be open, be able to be open about their status. So that's why this working with networks, I think, is really important, and working on creating the skills. I'll give you an example of some work that was done in India to reduce around stigma reduction with networks of sex workers, both male and female sex workers. And so a lot of the work started within the network around building the skills to interact, say, with the media or with healthcare workers, and thinking about, and then having that backup, that safety network. And then they went into health facilities and started a campaign. And they started their campaign by giving roses to all the doctors who had treated them respectfully. And this created a buzz in the hospital, and then they were able to build from that. And they built out this really quite involved stigma reduction intervention from that basis. But again, where it's illegal, yeah, that's a challenge. Again, we have the government, again, how we approached this was really getting different levels of buy-in, which I know you all know about being in the field, and working with this. It was interesting, for example, one of our most powerful trainers in Ghana was a Catholic sister. And you should have seen her do her sexual and diversity stigma reduction session. It was amazing. And she has become kind of a spokesperson, and she's an elder sister. She's the head pharmacist in one of the hospitals. So there's no easy answers because of the criminalization, but what we're finding is if you can create that space for contact, that you can start breaking that down. Of course, this becomes much more difficult now in the time of COVID, but the contact piece of it.
Thank you, Laura. Given time, I'm just going to allow one more of our panelists to make a comment before she has to step off, and then I think we'll go on with our next presentation, then have more time for questions at the end. Rose, would you like to comment?
Yeah, great, thank you. Hi everyone, this is Rose Wilcher with FHI 360, and yeah, Laura, just want to pile on the praise for what a great presentation that was, and explaining stigma, but also really just driving home that it is possible to address stigma. It does often feel like this overwhelming construct that isn't actionable, but it is. And I just wanted to, so I work on the Linkages Project, which is an HIV service delivery project focused on key populations. And so addressing stigma and discrimination, violence, and other human rights abuses has been a big part of Linkage's work. And to that end, just to add to the sort of set of resources and tools and trainings that you mentioned are available, we also developed a training curriculum called Health for All, which is designed to build providers' capacity to provide comprehensive, high-quality services free of stigma and discrimination, and with empathy to key population members. And I just wanted to reiterate, I mean, one thing we do as part of this training, and that Laura also mentioned is important, is bringing key population members themselves to the training for dialogue with providers and other staff members at the facility, and how important that is to breaking down, I think Laura, you described it as the us and them, but that is really just so critical and transformative for the providers. So just wanted to reiterate that. We've implemented Health for All in several countries and seen the powerful impact that can have. And the last thing I wanted to say was, it's great, Laura, to hear also about the measurement of stigma, because unfortunately, one of the things we've struggled with as a service delivery project is really being able to rigorously evaluate a training effort like rolling out Health for All, and being able to attribute changes in service delivery outcomes across the cascade, which are of course the outcomes that PEPFAR is most interested in, being able to attribute any changes in uptake of services to something like a stigma and reduction training. And so I guess, while it's great that you have these measures of stigma, do you have any examples or evaluations where you've been able to attribute changes in stigma at the facility level to actual changes in service delivery uptake? Thank you.
Okay. Christine, do you want me to answer that question, or did you want to hold that? I know we need to get to the next question.
You're very kind to ask. I am nervous about time, so okay. I would like you to put that.
I can answer in the chat as well.
Okay, that would be great if you could put that in the chat, and also there are other questions in the chat that I see and on the Q&A. If you could answer those while we move on with the next presentation, would be terrific.
Sure,
so
and I can put my email in there if people have other questions too.
That would be great. Okay, we'll move on to Elizabeth, who's really going to talk about this idea of how we can address stigma and how we go about rolling out PrEP. So over to you, Elizabeth.
So thank you very much, and greetings to all of you from wherever you are in the world, and thank you, Laura, for doing such an excellent job describing stigma and describing interventions that have worked. So my role today will be to tell you a little bit about our experience delivering PrEP in Kenya. And I work on a project that is catalyzing PrEP scale-up in public HIV care clinics called the Partner Scale-Up Project. So next slide. So I know you know this, but I really wanted to remind all of us that PrEP really works for all people, for people of all ages in which studies have been conducted. It works for all gender types, and PrEP works for all at risk, depending on your mode by which you're at risk of acquiring HIV, be it vaginal or penile or rectal or through injection drug use, and that it works for all who will take it and will protect them from getting HIV. Next slide. And that PrEP is really empowering, and through some of our qualitative work that we have done is that we've learned that PrEP reduces anxiety, increases communication and trust, increases sexual pleasure and self-efficacy, and it's so an empowering intervention that people who are seeking it will be able to use to protect them from HIV. Next slide. And so I borrowed this from the AVAC Global PrEP Tracker. This was April 2020. And it just shows countries across the world that have PrEP programs, and there are countries that are huge numbers, and there are countries that have small numbers and are just beginning. Kenya today, we are at over 60,000 people who have initiated PrEP, and current of about 30,000 on PrEP. So it's a whole dynamic, it's a whole spectrum of PrEP initiations and PrEP programs across countries. But I want to show you this so that you realize that different countries are at different places. Next slide. And so I'll tell you a little bit about the PrEP program in Kenya. It was, it's led by the Ministry of Health, the National AIDS and STI Control Program. And so we had guidelines that were revised in 2016 that now said, you know, yes, we recognize that PrEP is an important intervention, and we are going to put it as one of the interventions that can be provided to people at risk of HIV, including other combination, you know, combining with other known HIV prevention interventions. And so we moved from launch of guidelines, and soon after formed a technical working group that had subcommittees and were dealing with different aspects of PrEP delivery. And then in November had an implementers meeting where researchers, implementers, Ministry of Health, and all people who are stakeholders in the PrEP field, religious leaders, were at a meeting where, you know, data were presented about effectiveness of PrEP, and different people were able to speak about what their anxieties are about PrEP delivery and what the opportunities are. And so then we had some demonstration projects start up, and others were ending at that time. And by come May 2017, then we developed an implementation framework. And then come May 2017, we had a national PrEP launch. It was a big, big meeting, and ministers were, the Minister of Health was there, and the NASCOP, National AIDS and STI Control Program people were there, and different stakeholders were at this meeting, and there was lots of media presence also to share that launch. Next slide. And so a little bit about the program is, as I have said, is overseen by the technical working group that has various subcommittees. And I highlight the service delivery subcommittee that sat down and said, you know, where are we going to deliver PrEP from? What are the requirements, you know, what venues, how will people get to those venues, you know? And then the communication subcommittee that was tasked with, you know, what messaging out and creating demand for PrEP for people who are at risk of acquiring HIV. And so very, very specifically, the TWG and the subcommittees were very clear that we will not call out a specific population when saying who PrEP is for. So we did not say PrEP is for sex workers, or PrEP is for MSM, or PrEP is for HIV serodiscordant couples. Instead, we said PrEP is for anybody who's at substantial risk of acquiring HIV, but then defined or detailed out what is likely, what behavior is likely to be high risk behavior. So PrEP is for anybody who's at risk of acquiring HIV, and examples would be, you know, transactional sex, having a partner who's HIV positive, and things like that. So not calling out people specifically and saying that this is for you. And so also said that, you know, anyone could access services from any delivery point. So even though there, for instance, that there's PrEP being delivered in a HIV care clinic, and many of the people coming to a HIV care clinic would be partners of HIV serodiscordant couples, partners of HIV infected people. Anybody else coming into that service point could receive PrEP, okay? Anybody going to a family planning clinic, if they're offering PrEP, could receive PrEP from that service. And it was very clear that if you're delivering PrEP, then open it up for anybody to come and get service from that delivery point. Next slide. And we came up with the campaign identity called Jipende Jiprep. This was a nationwide campaign targeted at, you know, general population. And the purpose for this campaign was for people to be aware of PrEP, so increasing demand for people to know that there is PrEP, to know what it is, and to give them an opportunity to self-assess for risk and then allow them to seek service. The campaign Jipende PrEP is a Kiswahili word that translates to love yourself and prep yourself. So it's an appeal calling to yourself to want to do good to yourself, yeah, and to feel good about yourself. So that it almost feels like it's a good thing. I care about myself, and so I am going for this PrEP. And I feel good about myself, and I want to go for this PrEP. Rather than, oh, I am at risk of HIV, or I am from this key population, this population type, and so I need to go for PrEP. And so the purpose of this was to also increase visibility and allow people to then start seeking services. Next slide. And I want to call out, so for demand creation, this is small bits of newspaper articles that came out after the national launch. And they were in, the national newspapers, they were on the internet, it was everywhere, but that it did not say that PrEP is for anybody. It said, it did not call out populations for PrEP. It said PrEP is going to help protect you from HIV. PrEP is going to reduce our HIV incidence, and it came out at about the same time with a self-testing kit. And before this, there had been quite a bit of engagement with journalists to make sure that they understand what PrEP is and understand the approach that the ministry is taking, so that when they report, they're going to report it in the way that ministry wants it, or in the way that is going to be beneficial for everybody, that it is something to protect us from HIV, all of us, and it's a good thing to do. And so we had quite a buzz for a couple of days after the national launch, and it was a very positive vibe actually with the launch. Next slide. And then we had things for delivery, for demand creation, Twitter feeds that were talking about PrEP, and you have general population, you have, looks like happy people, positive vibe, having fun, living their lives, but they're depending PrEP, they're loving themselves and they're prepping themselves, and it's an attractive thing to do, so that if you're seeking for PrEP, you are a happy person, you're looking out for good for yourself, and you're not stigmatized, you're not defined as any particular population. And that was really the intention of the program from the very beginning. So we had this going on for quite a while, they still are, not so much now, but we have this, videos, posters and ads on Twitter that people that keep popping up and people can see them. Next slide. But having said that, we were also very aware of the fact that our epidemic is concentrated in several counties. So not the whole country does not have the same HIV incidence. There are a few counties that have much higher incidence than others. And so it made sense that we focus there, place efforts there to deliver PrEP. So even if we said PrEP is for general population, it's for anybody who's at risk, you can get it if you go to a public health facility. But there was a very deliberate effort to make sure that in places where there's high incidence, the services are accessible and are available sooner. So that was our starting point, that in counties of high incidence, but the message even there was PrEP is for anybody who's at risk of acquiring HIV, and then we detail out what is considered high risk. And so we started with the high incidence and medium incidence counties, and now is spreading out to low incidence counties and doing PrEP delivery now in public health facilities almost everywhere in the country. And remembering that, it's an intervention for all populations, it's for multiple populations, it is, but not calling out populations in which there would be a sense of stigma and you know, labeling people as high risk over others. Next slide. And then what happened soon after that, then we, mainly the partners who are involved in PrEP delivery, started developing tools and posters and other material that seemed to target high-risk populations. So even without calling them out, so you would have a poster that is, you know, a young girl, and is designed in a manner that is going to speak to a young girl, or a poster that's going to speak to a partner of a HIV-infected person. And these were developed by partners and put in strategic places. So if you have, for instance, the DREAMS project had some of this material delivered to them. You had material in family planning clinics that would speak to women. We had material in HIV care clinics that would speak to partners of HIV-infected persons. So now being very targeted in who we are getting to receive PrEP, even if we're not calling them out, right? We're not calling out and saying that PrEP is for this population, but where that population would be, there will be material that will speak to them, and there will be services that are accessible to them. Next slide. And so, yeah, and I share some of these posters. So the first poster is actually from my project, and, you know, speaks to HIV prevention method for a HIV discordant partnership. The next is a young woman, and the next is a poster that was targeted for MSM and was, you know, and says, if you're interested, this is the contact information, and they give contact information for an MSM clinic or contact information for, you know, a drop-in center for key populations. And that way then the people most at risk who are now in these key populations will be able to know where to get services. Next slide. And so for at the ministry level, I mean, it is still important to know whether we are getting to people who really need PrEP. And so our clinic encounter form will allow you, has a behavior risk assessment, and so can be able to somewhat figure out the risk profile of the people who are coming to access PrEP. I think what you can't see also is there's a demographic section that providers would fill out whether your general population or key population or partner or population type as you're coming into services. So that even if it is open out there that anybody can access PrEP, at the national level, we'll be able to figure out who actually is accessing and receiving services. Next slide. And so on this, I now present national data, and you begin to see that, well, over time, we have had an increase in commodity consumption. We had a little bit of drop with the COVID story, but generally there has been an upward trend of TDF FTC consumption in the country. Next slide. And then also we begin to, so based on data from the clinic encounter form, we're actually able to see, are we reaching populations that are most at risk? And so, in our country right now, more than half of the people who have had PrEP are in HIV discordant partnerships, but you can see that you have members of general population who feel at risk coming for PrEP. You also have MSM at about 3%. We have sex workers at about 13% and people who inject drugs. And then you also see a distribution by age and by gender over the period. And this is data by of April 2020. So we are, even with that kind of very open, wide saying anybody can come for PrEP, we are getting to populations that truly need PrEP. Next slide. And so, and this is my last slide, is sharing early lessons, is that I think what was very important is that we had national and county government involvement from early on and agreeing on the message and agreeing on the approach and the strategy for PrEP introduction. And so anybody else who was getting into that space knew what the approach is and had to fit in that approach. And then also by fitting in with existing program facilities made it also easy. So we had common training material that, you know, had the same message for training. and the requirement that wherever you are, if you're providing a PrEP service, you provide it to whoever who comes seeking that service. And remembering that we need to avail services to all who are at risk of HIV. Next slide. And so, yeah, as I end here, it's just to remind us all that PrEP is truly a powerful and effective intervention, and we really, really must strive to avail it to all as they come, without calling them out. And that makes it easier. It makes it easier for people to come in when they feel that they're not going to be labeled, they're not going to be stigmatized, that if you're seen walking through that door, you truly are a certain population type. I think has helped us quite a bit in starting our PrEP programs. Of course, we do experience a little bit of stigma and are working towards it, but I think our initial approach of demand creation was really key and important in ensuring that PrEP gets accepted by all, and facilitating and providing an avenue for people to receive PrEP. So thank you very much.
Thank you so much, Elizabeth.
I just want
go ahead.
to acknowledge the PrEP users from whom we continue to learn. I want to acknowledge Mary Mugambi. She is the PrEP program manager who couldn't be here. But all of this has really been done in collaboration with the technical working group in Kenya.
Thank you, Elizabeth. Yeah, I think that what this highlights is how important these, in order to address the stigma from the very beginning, we have to be very thoughtful in the kind of communication and messaging that we create, whether at the national level or at the project level around PrEP. And one of the other challenges is, of course, that oftentimes PrEP is delivered through the HIV service delivery channels that exist, because oftentimes it's funded by PEPFAR and has reporting requirements that go along with that. So I guess part of my question for you would be, to what extent do you think that, I recognize in Kenya that actually a lot of the service delivery is through HIV channels, and you have had this demand creation campaign, but to what extent do you think you have been successful in addressing stigma versus what more work is there to be done?
Well, I think we have done quite a bit in addressing stigma, and quite a bit remains as well. The early messaging was really, really important. When you think about people who might have had challenges with PrEP delivery, and especially early fora and early meetings where we had challenges with religious leaders and people feeling that, you're allowing people to continue with bad behavior and having a moralistic approach to PrEP delivery and feeling that you shouldn't be doing this. Our early messaging was really important to address some of these issues and saying, people may be at risk. People have partners who are positive. People have partners who you do not know what they're doing out there. And so the religious leaders felt that, well, yes, truly, this is our place that we can address this issue by allowing PrEP delivery to continue. That said, I think places like HIV care clinics are difficult places to do PrEP for populations other than partners of HIV infected partners. But what has been very interesting is that facilities and providers have acknowledged that this would be the case and have come up with different approaches to mitigate stigma within their clinics. So they will do things like fast tracking. We don't want to keep this negative person in the clinic too long because they will not be comfortable staying here for long. And so we'll want to fast track them, or we'll do a one-stop shop. So let's have a place where people who want PrEP can quickly come in, get the service and leave. Or having different hours, or allowing them to come a little later or much earlier in the day to get services. So clinics are aware that this could be, and maybe because of the background of HIV care and the stigma that has been with HIV care, and are now very early on as the program starts trying to come up with ways in which they can address this at the facility level.
Thank you. Elizabeth. I do think that I think Kenya is a very important example, and your data showed it so well, that messaging PrEP for all helps reduce stigma, and yet it does not open Pandora's box of everybody, the worried well, being on PrEP. You are still able to get those who are at risk on PrEP. And so I think I think we have heard from other programs in countries of a concern that if the messaging is PrEP for all, that they will suddenly be flooded with so many people, everybody wanting PrEP, and it will overwhelm the system. But in fact, what Kenya shows is that you can message that and still target PrEP for those who it's the appropriate choice.
That's true.
I think given the time, we're just going to go on to our special presentation, and then we'll come back for some final thoughts or reflections or questions. So I'm going to turn this over to Elmarie.
So good day, colleagues from all over the world. And what an incredible privilege for me to be able to tell you a really quick story. And so before we play the public service announcement, the video, just a quick little bit of context for that. And so I think most of you know in 2016, something really incredible happened in South Africa, and oral PrEP was started made available to certain populations. And we know from Elizabeth's presentation, we know that PrEP works. And so we realized under the Options Consortium that, if we're going to take PrEP to populations such as adolescent girls and young women, then we're going to have to engage with them and ask them how they feel about this. We're going to have to tell them a little bit about it. We're going to have to give them a space where we can build their capacity on what oral PrEP is, and then allow them to share their honest feedback with us, and to really let us know, do they think that this little blue pill with a really big heart can make an impact and can make a difference. And we know that in South Africa, adolescent girls and young women are one of the most at-risk population groups in terms of HIV, with about just under 1,300 new infections every week. And so, like I said, we went to them and we asked them some questions. We tried our best to make friends with them and to understand what is it that concerns them, and what is it that gets them excited, and what is it that they're thinking. And so a lot of things came up, and so they wanted to understand more in relation to, what happens inside my body if I take PrEP, what is going on in there. They wanted to know, the regular kind of questions like, should I still use condoms? And, some of them even had concerns around the fact of having to take an ARV just to prevent themselves from having to take an ARV later if they're HIV positive. And so they really had us scratching our heads. But one of the big things that came up for us was that a lot of these young women said, this is really incredible, because this is something that I control, and this is something that empowers me, and this is something that I can put on my hand and nobody else has to have a say about it. But what if people see me taking PrEP and they see that it's an ARV and they think that I'm HIV positive and they stigmatize me? Or what if people see me taking PrEP and they think, you shouldn't be having sex, and they stigmatize me because of that? And so what we did was we really listened to them, and we went back to the drawing board. And one of the other pieces of advice that they gave us was, number one, you have to make PrEP famous. And number two, if you want to make it famous with us young people, you need to meet us where we are. And that's on our screens in the digital world. And so we went back to the drawing board and we had more discussions with young people. And we thought, how about creating some videos that could address all of these questions of young people, and we can put it out on social media? And so young people helped us to write these scripts for these videos. And one of these videos specifically talks to the issues around stigma. And it specifically talks around making PrEP famous and sort of giving a young person that role model, that aspirational feeling, seeing somebody on the screen that she can relate to, who's saying, you know what, PrEP if I'm HIV negative, and ARVs if I'm HIV positive. This is my life. And so another suggestion that we received was to use really South African young actresses that they can relate to. And who better than MTV Sugar? And so what we want to show you today is one of these videos that goes to addressing some of these concerns in relation to stigma. And so before we show you this video, just one little snippet to say what happened after we shared these videos. So we had a lot of views, we reached a lot of young people. More importantly, we had a lot of young people who engaged with us on social media. And we've even seen now that a lot of young people have started to make their own empowering videos and posting it on social media. And so that really for us is the big win. And so with that, I have very little time, so I'm going to hand back over to our host to play this video.
It ends with me. It is a journey that starts with an HIV test but ends with me. Positive or negative. It ends when I choose to take my ARVs for HIV treatment. Or my PrEP for prevention. Just one pill every day. It ends when I decide to defy the limits that are placed on me. I am the solution. I am every girl, every woman that dares to declare that this ends right here, right now. We are the generation that is everything. Built on the hopes, the dreams, and fears of those before us. All that potential, just not how you imagined it. Do not stigmatize me. Do not discriminate against me. But recognize that I am powerful in every way. In my way. Let me bless you with my positivity. For I am the gonna touch the sky girl. Have to keep my grades up, girl. My brows, my hair, my nails on fleek, girl. The currently in a relationship, girl. The choir, shop, or corner girl. School, home, or party, girl. Big plans and even bigger dreams, girl. Powerful and unapologetic, girl. Taking one pill a day and killing this game, girl. Living HIV-free and keeping it real, girl. Continue to conquer, girl. Ask me why I take PrEP. Go on. I choose protection. I choose control. I choose my future. No apologies. I'm ready to be done with myself. One pill a day. Every day. For as long as I need it. No questions asked. No stigma. PrEP is a new, safe HIV prevention method for HIV-negative people to reduce their risk of becoming infected. PrEP needs to be taken daily for 7 days before you have more than 90% protection, and then continue taking it for as long as you need it. My way or the highway, girl. My PrEP power. PrEP up. No fear.
Awesome. We're getting positive feedback. Oh, sorry. I guess I missed the very last bit there. Yeah, thank you, Elmarie. Do you want to make any final comments on the videos?
No, just to encourage people to go and watch the rest of the videos. You know, it was such an interesting process. And I mean, Christine can tell you about this. She's very humble in not saying that originally the base idea of this came from her, if I'm not wrong. And so it was a wonderful experience working with young people, sharing the scripts with them, getting them to, you know, write with us and improve and to give their own ideas. And so you'll hear there's a lot of young language in there that definitely didn't come from me because I just don't have that vocabulary. And so it was a wonderful process. And I think we're seeing the, you know, the fruits that is bearing. And so I would encourage everybody to make friends with some young people and try and do your own little project like that.
Yeah, thank you so much, Elmarie. And I note one comment in the chat that the video is biased toward females, so males might feel excluded. I do want to note that actually the funding for these videos was from a project, the Options Project, that was specifically focused on PrEP for adolescent girls and young women. So that's why that was the target population. But there could definitely be similar videos made for other groups and be more inclusive. We, you know, those videos are free and available for anyone to use and access. And I believe Elmarie shared that link in the chat, and there will be more in the resource sheet that we send out. I just want to sort of, you know, tie this all together, that what, you know, we heard about what stigma is, how, you know, from Laura, what is stigma? How do we define stigma? How do we understand stigma? How do we address stigma? And what are some intentional things that we can do? It's very hopeful, I thought, with some of the programming that could take place. And then I think through Elizabeth's presentation and the video that Elmarie shared, it also showed how important the mass communication and media, and then we didn't go into it as much, but also then the more individualized community engagement is in terms of messaging PrEP in a way that is destigmatizing. And this is critical for all of us, and to be very thoughtful about this as we continue in our efforts for PrEP scale up, to be really thoughtful about how is our messaging around PrEP contributing or dismantling the stigma that is associated with this product. And we need to dismantle it so that we can make it more accessible and easier for young people who need it to use it, or for all those who need it to use it. I want to just, we do have a few more things I want to talk to you about, but I do want to pause to see if anyone on the panel would like to make any comments or reflections on what we've talked about today. And if no one wants to jump in, I actually have one other sort of question for the panel, which is, you know, particularly for Laura with these, with our shift now with COVID-19 and so much of our work having to go digital and figuring out creative ways to engage with clients in virtual ways. I'm wondering if some of the interventions that you described in trainings, if you have started to think about how to make those virtually available and accessible.
Hi, thanks, Kristen. Yes, it is a challenge with COVID on many fronts, and it's something we've been thinking about. Some of the interventions, we are starting to think about the materials and how to make them online interactive. We just finished a study in India where we had done what we call a combined intervention. So the health workers did half of their sessions self-learning on tablets, and then we had one in-person session. And we're thinking about how you know, we know that in-person physically is, with stigma reduction, is probably the best way to do it, but trying to think about how we can create sort of the virtual in-person sessions. So it is, yeah.
We will wait with bated breath for you to share those resources with us all.
Well, it's going to take a while to get them together. We're still looking for the resources to make the resources available. Sure. But I think it is possible, and I think it's, you know, for people who have those skills, you can certainly take the stuff we have and work with it too. It's open access, so.
Thank you. Well, let's move on to the last few slides, and we do have a poll, so please just wait for the very end to share some feedback. I think one more slide. Thank you. So, you know, in today's session, we had almost 200 people participate. It's really terrific to have this level of engagement from around the world, literally from many, many different countries, and folks who are, I can see from the list. I know I'm so sad that I can't share the attendee list with all of you who are the attendees. Some Zoom won't allow us to do this, but I just wanted you to know that you're here together with colleagues from many different countries and from representation from national governments. I see some of my colleagues who are from the MOHCC in Zimbabwe, for example. I see implementing partners. I see funders and donors, and so it's just terrific to have this participation. We are going to have our next PrEP learning session on August 27th. We're going to talk about community-based delivery of PrEP. And then on September 24th, this has not yet been set, but I am hoping we will talk about the dapivirine ring. The dapivirine vaginal ring is a HIV prevention product that has been under regulatory review for a long time. And we are hoping to hear some news on that tomorrow. So those of you who are paying attention to the news, keep an eye out. And then depending on the outcome of that regulatory review from the EMA, we may be able to focus on that in September. All the information and recordings and resource sheets from these sessions are available on our website, on prepwatch.org at Virtual Learning Network. And we will be sending out about a week from now the resource sheet for today that answers questions. Yeah, here's the page on that. We have also changed our Twitter because the Options Project is ending. We have changed our Twitter to @PrepLN, @Prep Learning Network, and these webinars will continue. The Prep Learning Network will continue under funding through the EPIC and RISE projects by USAID, and I will continue to host, so please come back. And next slide. We have an exit poll, so you can go ahead and launch that and folks can fill that out while I just give a warm thank you to our speakers today, to Laura and Elizabeth. Really appreciated your in-depth sharing, and Elmarie, the really just inspiring video that you shared of young people in South Africa embracing PrEP. Also to our panelists and those who were able to contribute to the preparation of this, a big thank you, and to all of you who attended. So please do complete the poll. We'll stay on the line just a few minutes so you can complete the poll, and we look forward to seeing you next month. Same time, same place. Wish you all a great day and evening. The panelists, you are welcome to, I see Michelle asking me, you are all welcome to drop off now. I'm just sitting here as a good host, you know. The host is the last one to leave, so you are all welcome to head on with your day.
Hey, thanks, Christine.
Thanks.
These are always really interesting.
Thanks for inviting me. This is Laura signing off.
Thank you, Laura.